Dr. G. Oxygen, a beautiful thing, until it isn't. Lecture pitfalls from pediatric intensive care. 1. Too much oxygen does not mean better care. Oxygen is not a vitamin supplement. It is a drug with side effects. Hyperoxia can produce oxidative stress, vasoconstriction, and additional lung injury. An FiO2 above 0.6 for prolonged periods should always make you uncomfortable. A patient drowning in oxygen may still be quietly drowning in inflammation. 2. Hypoxemia is not the same as hypoxia. Do not treat the monitor, treat the child. A normal saturation does not guarantee adequate tissue oxygen delivery. Shock, anemia, poor cardiac output, all can produce profound tissue hypoxia while the pulse oximeter smiles politely at you. Numbers are reassuring. Perfusion is reality. Blind trust in pulse oximetry. Pulse oximetry is a wonderful invention. And like all wonderful inventions, it occasionally lies. Poor perfusion, methemoglobinemia, carbon monoxide poisoning, motion artifact, dark nail polish, severe vasoconstriction, all may distort SpO2 readings. The monitor is an assistant, not a philosopher, certainly not a god. 4. PaO2 and SaO2 are different creatures. One may look healthy on the monitor while quietly suffocating in physiology. A patient can maintain an apparently acceptable saturation while PaO2 falls dangerously low, especially during hypoventilation and hypercapnia. Blood gases remain important, even in the era of glowing screens. 5. Impaired autoregulation in premature infants. Premature infants are not miniature adults. Their eyes and brains do not forgive enthusiasm. Excess oxygen in preterm infants increases the risk of retinopathy of prematurity, bronchopulmonary dysplasia, and neurologic injury. In neonatology, precision is kindness. 6. Failure to reduce FiO2 after stabilization. Leaving FiO2 at 100% after stabilization is like driving through London at noon with high beams on. Useful in crisis, absurd when forgotten. Oxygen should always be titrated to the minimum effective level. The goal is not impressive numbers. The goal is safe physiology. 7. SpO2 during shock, a dangerous comfort. If the child's hands are cold, the pulse oximeter may simply resign from the conversation. Peripheral vasoconstriction and shock can make pulse oximetry unreliable. This is the moment when clinical examination becomes more valuable than technology. Touch the patient, not only the screen. Delayed transition to non-invasive support. There are physicians afraid of intubation and physicians afraid of extubation. Between them sits the child trying to breathe. Delayed escalation to HFNC or CPAP can increase respiratory fatigue and worsen outcomes. Timing matters in intensive care, often more than heroics. 9. Ignoring individual saturation targets. In congenital heart disease, 85% may be magnificent. Not every child should have a saturation of 100%. Some patients live safely within entirely different physiologic mathematics. Medicine becomes dangerous the moment we forget individuality. 10. Oxygen, just in case. Whenever somebody says, "Give some oxygen, it can't hurt," a physiology textbook quietly closes itself in despair. Even short periods of unnecessary hyperoxia may be harmful. There is no harmless intervention in intensive care, only interventions whose risks we understand or fail to. Young doctors often believe oxygen is the safest thing in the ICU, usually right before they discover that even air can become dangerous when medicine stops thinking.